Hey everyone. So this is a two-part series that I am making on case protocol 4, which is about anaphylaxis and shock. And for those of you who know me, this is a topic I'm particularly interested in. And the reason I like this topic is because I think that if you understand the principles, it's a topic where you can work out everything you want to in terms of the reason why clinical signs present, and you can predict the clinical signs that actually present. And I'm going to enjoy sort of talking through these topics as we come through them. So I thought in the first part of the video, we'd go through shock before we go through anaphylaxis, which is a subset of shock. And shock actually comes up all over the place. It comes up here in anaphylaxis. At the end of this case protocol, there is like a diversion towards septic shock. It comes up as a complication in the myocardial infarction case. It comes up in the pulmonary embolism case. It comes up in the pneumothorax case. So it sort of just pops up all over the place as this endpoint, as in when everything goes wrong, you become shocked. And so I think it's worth going through what shock is and the different subtypes of shock, just so you can organize it in your own mind. And that's the plan for this video. So let's start off with a definition for shock, because that's going to let us build upon it and really tackle this topic well. So shock is a state of circulatory failure characterized by tissue that is inadequately perfused to meet the needs of the body. Right? And there's a lot of definitions for shock that you'll find online. Pick one that makes most sense to you. I think this definition will make more sense to you as we go over the next couple of slides. But just remember, it's essentially, in the most simple terms, the human body needs blood to perfuse its organs. When blood perfuses organs, oxygen and nutrients get delivered to those organs, and carbon dioxide gets taken away from those organs. Shock is a state where that perfusion, that delivery of oxygen and nutrients, doesn't happen. And because of that, there is dysfunction of the organs. So to start talking about this topic, let's talk a little bit about the physiology of it. Tissue perfusion is determined largely by the blood pressure in the human body. Now remember that your blood pressure is actually determined by two factors. One is your cardiac output, and the second is the total peripheral resistance of your vasculature. So you can actually already see two determinants of tissue perfusion. And I guess, if you're thinking ahead, two determinants as to why you might get inadequate tissue perfusion or shock: a decreased cardiac output or a decreased total peripheral resistance. Cardiac output itself can further be broken down into the stroke volume, the amount of blood ejected with each contraction of the heart, times the stroke rate, the amount of beats, the times the heart beats every minute, right? So those two things determine the cardiac output. And then stroke volume itself is determined by three factors. You might remember this from phase 1. The first is your preload. That is essentially the amount of blood that is filling the left ventricle at the end of diastole, or the end diastolic filling pressure. So the more blood you have at the end of diastole, the more blood that can be pumped out when you have systole. The second factor is the contractility of the heart itself. So the harder your heart beats, the more blood it ejects. And the third factor is the afterload. That's the resistance the heart is pumping against. So the higher your afterload, the less your stroke volume. So what this essentially provides you with is a structure to categorize the subtypes of shock. Because the subtypes of shock are simply through deficits of each of these components. Let me show you. So we know that the end product is going to be a decrease in tissue perfusion. Take a decrease in total peripheral resistance. If you have a decrease in total peripheral resistance, these categorize the distributive shocks. The distributive shocks actually include things like septic shock, which is the most common type of shock we see in hospital, anaphylactic shock, and neurogenic shock. These three things are three very different pathologies, but what they have in common is that they cause an increase in peripheral vasodilation. And because they cause that increase in peripheral vasodilation, they reduce your total peripheral resistance, they reduce your blood pressure, and they impair perfusion. And we're going to go through each of these more in a second. Then we have the types of shock that limit your cardiac output, right? And it's best if we go straight down to here to subclassify them. Shocks that are associated with a decrease in preload are your hypovolemic shocks. Hypo meaning less, volemic meaning volume. Shocks to do with a low amount of blood in the circulation. So, patients who are undergoing massive hemorrhage or fluid losses through the gastrointestinal tract or through burns have a lower circulatory volume. If you have a low circulatory volume, you cannot fill your left ventricle at the end of diastole as well as if you have a normal circulatory volume. Because of that, you have a lower preload. Because of that, you have a lower stroke volume, and because of that, you have a low cardiac output, and because of that, you have a low blood pressure and hence tissue perfusion. There's also shocks associated with poor cardiac contractility. So when the pump actually fails. Now, things such as myocardial infarctions, things like cardiomyopathies, essentially we refer to these intracardiac pump failures as cardiogenic shocks, right? And then there's problems when you have too much of an afterload, too much resistance to pump against. And we can think of the obstructive shocks in this category. Your common obstructive shocks are things like your tension pneumothoraces, your pericardial tamponades, and your massive pulmonary embolisms. All these pathologies create such a pressure on the output of the heart that the heart isn't able to pump against them, right? And because of that, you have a decreased stroke volume, decreased cardiac output, decreased blood pressure, and decreased tissue perfusion. So in summation, this is the physiological basis for shock. It's to give you a very general structure of what shock is and why it can happen. With the next few power slides, we're going to go through it all again systematically in a bit more detail. So shock can be classified into four main types: hypovolemic, cardiogenic, obstructive, and distributive. Now, the way I remember these four different types of shock is I don't generally go back to the physiology of it all. I mean, I always like to remember that in the back of my mind, but when I think about how to categorize shock, I think about it as a bit of a story. I think about what you need to take place, the events that need to take place for circulation to adequately perfuse the tissue. And the first thing that needs to happen is your left ventricle needs to fill at the end of diastole. And if you don't have adequate left ventricular end diastolic filling pressure, you have hypovolemic shock, right? The next thing that needs to happen, if you've got a left ventricle that fills well at the end of diastole, is your heart actually has to pump, right? You have to have an adequate pump. And if you don't, that's cardiogenic shock. The next thing is the heart needs to be able to pump against the load it's pumping against. And if the load is too high, in the case of a big pulmonary embolism or a tension pneumothorax or a pericardial tamponade, then you have an obstruction to blood flow or an obstructive shock. And finally, if you have an intact heart that's pumping well, you need to drive that blood forwards rather than sideways. And if you have total peripheral vasodilation, you have distributive shock. So that's how I think about it in my head. Feel free to think about it any way that you feel comfortable with, but the main thing to take out of this slide is that there are 4 main types of shock. And just to reiterate why each type of shock takes place, hypovolemic shock takes place because of a reduced intravascular volume. If you have a reduced intravascular volume, you have a reduced preload or end diastolic filling pressure, and because of that, you have a reduced cardiac output. Cardiogenic shock is because you have an intracardiac pump failure, and that could be for a number of reasons we're going to go over. Obstructive shock is an extra cardiac pump failure. Like I said, there is too much load on the heart to pump against. And the distributive shock is because of severe peripheral vasodilation. So let's talk a little bit about the pathologies that can predispose you to the different forms of shock. So hypovolemic shock can develop as a result of massive hemorrhage, and hemorrhage can obviously develop because of a traumatic injury or massive upper GI or lower GI bleeds. There's actually a case protocol of a perforated duodenal ulcer that presents with hematemesis, melena, tachycardia, hypotension, so know that really well. There are also non-hemorrhagic causes of hypovolemia. So that's when you lose massive amounts of fluid through the gastrointestinal tract, through the skin. So the gastrointestinal tract you can lose because of diarrhea and vomiting. The skin you lose when you have massive burns, and also through the genitourinary system when you have a massive diuresis. You can also have cardiogenic shock, as we mentioned before, and cardiogenic shock can occur because of a failure of the pump itself, and things such as cardiomyopathies secondary to myocardial infarctions can lead to that. You can also have ventricular or atrial arrhythmias, bradyarrhythmias, tachyarrhythmias that stop you from pumping out blood effectively, and you can actually also have mechanical problems with the heart. So this is when you have valvular insufficiency, and not stenosis as you might imagine, but actually regurgitation. So for example, after myocardial infarction, if you have papillary necrosis and you have insufficiency of your mitral valve, and everything you pump when your left ventricle contracts flows in a retrograde fashion rather than antegrade fashion, that's mechanical cardiogenic shock, right? As we mentioned, you can also have obstructive shock, and that can be mainly because of 3 main things. First is a big pulmonary embolism. Second is a tension pneumothorax. Third is a pericardial tamponade, right? And then you have your distributive shocks, and it might just be worth talking a little bit about these because septic shock is actually the most common type of shock you'll probably see in the hospital. So because of a pathogen, you have a systemic inflammatory response syndrome that increases, as I said, it causes total peripheral vasodilation, and that leads to impaired tissue perfusion. But you can also have a systemic inflammatory response syndrome without having sepsis, right? And that occurs in massive pathologies such as pancreatitis, big burns injuries, ischemia, reperfusion injuries when you have trauma, and also when you have a big cardiac arrest and you suddenly get a return of spontaneous circulation. That's more things you see in ICU, so not too important for your exams. Anaphylactic shock, obviously very important. You get exposed to an allergen, you develop a severe allergic response. And then neurogenic shock is a very interesting type of shock. It's seen most often in traumatic brain injuries, and it's because of an interruption of autonomic pathways and an altered vagal tone, leading to a decreased vascular resistance. So this is a slide that I've actually taken from a talk given to us last year by Shadi Al-Wash. I don't know if you've ever met Shadi, but he is a fantastic teacher, and he helped a lot of us fifth years last year, and I think we're forever indebted to him. But if you ever get the chance and you bump into him at Liverpool, he's an intern at the hospital now, do try and ask him for a tute. I'm sure he won't mind. He loves teaching, and he is a fantastic teacher. So thank you to him for allowing me to use this slide. And what this slide essentially does is summarize what we've talked about over the last few slides. It's going through the main types of shock, the pathologies that lead to those types of shock, the physiology of the shock, and again, we talked about that on the first couple of slides, but it's also added the clinical manifestations of the different types of shock. Now, what I want to point out to you is the interesting thing about shock. All shock tends to present with a low blood pressure. Right? And cardiogenic and hypovolemic shock are very similar because their low blood pressure is a result of low cardiac output. Right? And because of that, they compensate for that in the same way. You get an increase in stroke rate and an increase in total peripheral resistance. Right? Because of that increase in total peripheral resistance or systemic vascular resistance, SVR, you have cold and pale peripheries in these patients. Right? And the systemic vascular resistance increasing, it has a second function of ensuring all the circulatory volume that you do have, or all the blood that you are able to pump, is perfusing the coronary and the cerebrovascular circulation, the most vital organs. And as a result, organs such as the kidneys miss out and you have a decrease in urine output. And because your baroreceptors notice the low blood pressure, you activate sympathetic overdrive, you have increased catecholamines circulating, and you become quite diaphoretic. Right? So it's very logical to work out the clinical manifestations of these two forms of shock. Obstructive shock, the clinical manifestations definitely depend on the pathology causing it. Like with every shock, you will get increased heart rate, low blood pressure, but a massive pulmonary embolism, tension pneumothorax, pericardial tamponade, they present in different ways. Tension pneumothorax classically presents with a diverted trachea, or deviated trachea. It also presents with decreased breath sounds on the side of the pneumothorax, and it presents with hyperresonance to percussion on the side of the pneumothorax. Cardiac tamponade presents with Beck's triad, and that includes low BP, soft heart sounds, and distended neck veins. And massive pulmonary embolism, depending on the size of the pulmonary embolism, the clinical presentation is quite varied. Right? Now, what the main thing is, I want to contrast these two forms of shock with distributive shock. Now remember, these two forms of shock are because of impaired cardiac output. It's not cardiac output that's the problem in distributive shock, it's the total peripheral resistance, right? Or the systemic vascular resistance. You can actually compensate by increasing your cardiac output. So in this form of shock, you actually have bounding pulses because the heart's beating harder and faster, trying to get blood to flow forward rather than sideways, and you actually have warm peripheries. So that's a very interesting contrast between the first two types of shock and your distributive shock. So since we've been talking about the clinical manifestations of shock, I think it's worth mentioning at this stage that shock isn't a binary term. It's not like you either have shock or you don't. It's actually a physiological spectrum. and that any inciting event, an infection or an injury, has the potential to progress to shock if not managed appropriately and in the right amount of time. For example, say you have a stab wound to the abdomen and you have the knife goes into the spleen, right? And initially you might lose, say, 10% of your circulatory volume. Because of that, you might have a lower circulation volume and you have a lower end diastolic filling pressure, which leads to a lower stroke volume, which leads to a lower cardiac output, which leads to a lower blood pressure. You can actually compensate for that amount of blood loss by increasing your heart rate and restoring your cardiac output and hence your blood pressure. However, if the blood loss continues to 20-30%, and there is no arrival of an ambulance or the patient doesn't come to ED and doesn't get a blood transfusion or doesn't get an operation to try and stop the bleeding if it's ongoing hemorrhage, then the compensatory mechanisms will become overwhelmed and the signs of shock appear. So the tachycardia won't be able to compensate any longer and you get hypotensive, diaphoretic. You might get a metabolic acidosis because of impaired tissue perfusion, the conversion to anaerobic metabolism, a high lactate and a high CO2, and impaired perfusion to the kidneys is often the first organ that you can see dysfunction in, leading to oliguria. So finally, let's talk about the consequence of shock. What is the impact of decreased perfusion on the different organs? Well, as you can imagine, with the heart, you can get myocardial infarctions because of impaired perfusion. And we need to be careful about this because a myocardial infarction can be the cause of shock in form of cardiogenic shock. But as you can imagine, in something like septic shock or hemorrhagic shock, you have an increased activity of the heart because it's trying to compensate for low blood pressure by beating faster. So increasing its stroke rate is also increasing its metabolic demand for oxygen. And because of the low blood pressure, for whatever reason, you actually have a decreased oxygen supply. So you've got an increased mismatch of demand and supply for oxygen, predisposing it to a myocardial infarction. In terms of the brain, decreased perfusion means that you can get a hypoxic or hypoxemic encephalopathy. And in more severe cases, you can get a watershed infarction. Now, you might remember this from reading about strokes, but a watershed infarction is essentially ischemia that occurs in the most distal aspect of the anterior and posterior circulation. So although you have a collateral circulation to your brain, there are parts of the brain that are at the most distal aspects of both these circulations, and they're the first parts of the brain that become predisposed to hypotension and hypoperfusion and are likely to get infarctions before other areas of the brain which are more proximal in the circulation. The lungs, if you have a low blood pressure in the pulmonary circulation, you have dysfunction of your alveolar capillary membrane. That can initially lead to pulmonary edema, but eventually lead to this entity known as acute respiratory distress syndrome. And that's a whole topic in itself, a very difficult entity to manage in the ICU with a very high mortality to this day. If you have hypoperfusion of the kidneys, the first part of the kidneys that gets affected are the tubules, and the tubules are very metabolically active in the kidney. They have a lot of pumps, and so you have acute tubular necrosis. The gut is actually one of the few organs in the body that lacks an autoregulatory system, and what that means is that other organs like the brain are pretty good in that with fluctuations of blood pressure, they're able to auto-regulate the flow, so they're able to compensate for hypotension and hypertension by decreasing and increasing the the resistance of their muscular arterioles. The gut actually doesn't have that system, so it finds it very hard to deal with any form of hypotension, and you can develop hemorrhagic enteropathy. And if you have hypotension of the gut for too long, you can actually have a passage of the intraluminal gut bacteria into the circulation of the human body, and that's how you can get sepsis from other forms of shock. So you have a transmural passage of gut bacteria into the systemic circulation. The liver, also affected by hypoperfusion, you can get central tubular necrosis. And don't forget, everyone always forgets that the blood can also be affected by shock, particularly in septic shock. You can get disseminated intravascular coagulation, which is a consumptive coagulopathy. And what happens here is you get lots of little thrombi forming in the circulation, and because your clotting factors are being used for those thrombi to be created, you become coagulopathic and you're predisposed to bleeding from other places. So in summary, that was part 1 of this 2-part series on shock, and we're going to be talking about anaphylaxis in the next part of the series. Again, any questions you may have, please message me. I'll be back at Liverpool next week, starting my emergency department term, and happy to take any questions, and it'll be good to start meeting face-to-face again and start doing these tutorials that way.